All right. Well, we will continue waiting for more people to join, but while we wait for other people to hop on, I'm going to start the baseline quiz. There should be 5 questions for you to answer, and we'll go through the answers at the end of the session. It'll be like pre, post, and then we'll review the answers at the very end. So all of these questions should be answered throughout the presentation. So you should hopefully learn what Dr. Gaye is hoping to convey with these questions, and we'll give it a few more minutes for other people to join in. Emmanuel, are you able to see the multiple choice questions that I put up?
Yeah, Jess, sure.
Awesome. How are you?
Doing pretty cool.
Good, good. I'm so glad to hear that. Victor, Bernard, are you able to see the questions that I put up?
Yes, please. I can see them.
Perfect. Awesome. If you want to go ahead and answer those, that would be fantastic. Thank you so much. Welcome, Maimuna. Thank you for joining us. There are some multiple choice questions up. We only have one respondent so far. It looks like 4 of you are still, we haven't seen participation yet. So if you want to go ahead and answer those questions while we wait for more people to join, that would be wonderful. Thank you so much.
Yes. I
Yes.
think you may have to reshare the question link.
Oh,
Yeah,
really?
I think that's the issue
Oh,
for them
it,
to be able to participate.
it looks like someone else just participated. Are you not able to see the questions?
Okay, cool.
Okay,
Cool.
perfect. And then it looks like I sent the wrong link to join the
I'm just
session
yeah.
just now. So I'm gonna resend the reminder link in these groups. Hi, Jimmy and Ruth. Welcome. Thanks for coming. Hi, Philemon. For those who just joined in, we have some multiple choice questions up right now to gauge baseline understanding about point of care ultrasound. If you want to answer those questions, that would be fabulous. We'll give it just a few more minutes. I think once we have 10 participants, we can get started, Abdoulie, and I'll introduce you. Thanks for your patience. Thanks for coming, Ruth. Good to see you. Thanks, Emmanuel. Thank you guys for participating in these questions. This is really great. And it looks like we've got lots to talk about, which is fantastic. All right, Sidwell is coming in from the waiting room. I'm going to go ahead and end the baseline quiz. And without further ado, today we welcome Dr. Abdoulie Gaye, who is an emergency medicine physician in the US. He is originally from the Gambia, and he actually taught ultrasound in the Gambia this past year. And we found each other through an SAEM Pulse article where I saw that he was working at Edward Francis Small Teaching Hospital, which is our biggest partner site in the Gambia. So without further ado, I'm going to let Dr. Gaye go ahead and share his slides. And he's going to talk to us about point of care ultrasound. And how useful it is in point of care like settings. So primary care, emergency medicine, we'll go through some basic applications. Go ahead, Abdoulie. I think you're muted, my friend, sorry. Still mute. Here, let me see if I can unmute you.
Okay.
Now I can hear you perfect.
Can you guys hear me now?
Yes.
Okay. Good morning, everybody. Well, sorry, I just say morning. It's probably not morning where you guys at. I think it's 11 here right now. I'm trying to share the slides here. Are you guys able to see it now or no? Is it showing up? No. Let me do it again. Got it? Great. Let me. Are you seeing it now?
Yes.
Okay, good. Good morning, everybody. My name is Dr. Gaye. As Dr. Pelletier said, I am originally from Gambia, but I did my undergraduate studies here in the U.S. and medical training as well. And I'm very glad to be part of this today. I'm not someone that you would consider a POCUS expert, but I'm certainly a POCUS enthusiast, if you can put it that way. It was a big part of my training, and I've seen so many cases where POCUS was sort of the winner. POCUS was what saved the day kind of thing. So, in cardiac ultrasound is what I would call the gold for POCUS, because it's where really the money is when you have a critical or sick patient in front of you. And today we'll go through the basics of it. We'll also talk about abdominal ultrasound. And mostly for that one, we'll focus on, the abdominal aorta. So just to get started here, we'll do this case by case basis. I have a couple of cases to share. One of these cases, actually, one of my cases, I did change some of the demographics for privacy purposes. And then we'll talk about basic cardiac focus. We'll talk about the cardiac views. We'll also talk about what is typically termed as the 5 E's of cardiac focus. We'll talk about what that means. And we'll also discuss basic abdominal ultrasound, specifically abdominal aorta, focusing on AAA, which is abdominal aortic aneurysm. And I will try to make it a very engaged discussion. I have some questions in there. If anyone wants to jump in and answer those questions while we're discussing, that would be great as well. All right, so we'll start with a case. So this was a 67-year-old gentleman came to the ED with the ambulance. Major complaint was generalized weakness, chest and abdominal discomfort. He had a pacemaker that was placed 3 days prior. He was discharged almost the next day after the pacemaker was placed. However, for the last 24 hours, he's had these symptoms. He's still generally weak. He can't really get out of bed because of his weakness. He is notably very hypotensive and tachycardic as well. He's answering questions. He's not confused. He does have some little bit of shortness of breath, but he's not hypoxic. His oxygen saturation was okay. All right, so just sorry guys, let me just trying to get my screen out. Having trouble with my
We can still see the presentation, Abdoulie. I think it's totally
you can
okay.
see it. I just can't see mine.
Oh, that's weird.
Yeah, for some reason it just.
Maybe try unsharing and resharing.
Now, let me see if I can just. Okay, I got it back.
Okay, great.
Sorry about that. So as you can see, this patient is pretty sick. It's very tachycardic. Blood pressure is 74/51. Respiratory rate of 20. Citing 97% of room air temperature is okay. You look at him, he's very diaphoretic, he's very weak. He's telling you that he's got chest pain, abdominal pain. Otherwise, his review of system is unremarkable. From an exam perspective, he's very toxic appearance. And he does have some lower extremity edema, but other than that, the exam is unremarkable. All right. So I would put it up to the audience. Any thoughts on what's going on with this patient? what is at the top of your differential, and what would you like to do next? Anybody?
Feel free to chime in out loud or in the chat, guys. Maybe give a one-liner summary, Abdoulie, of what we know so far about the patient.
Yeah. So far you have a patient who had just had a 3 days. I mean, 3 days ago he had a pacemaker placed. He's coming in with chest pain, abdominal pain, and is very hypotensive and
Well, I know for me, I'm concerned about septic shock since he just had an invasive procedure, but then we also have to think about cardiogenic shock. We have to think about, oh, good. Thanks, Ruth. She just chimed in. Undifferentiated shock. She said differentials, cardiogenic from ACS, obstructive from PE, also a great thought since he just had a procedure, and could have obstructive shock from pneumothorax if like one of the wires perforated, the pleura or something.
Absolutely. Yeah, and I remember this was actually a very busy night shift when I was working as chef, and there was a lot going on. And to make things worse, the computer was down. We didn't have any EMR, and things was very chaotic. So you needed something very quick to try to figure out what's going on. And again, initially when I heard the story, right, it was a med student that initially just walked in before me, and when they came in because I was in a different patient. So when I heard the story, it was, oh, okay, maybe there's some dissection going on here. It's got chest pain and abdominal pain. I didn't know about the pacemaker placement until I talked to the patient. And then when they mentioned that, and then that's when I go, okay, maybe there should be some cardiogenic shock here. And especially someone who just had a pacemaker placed, you're thinking about, okay, did they perforate anything? Did anything happen during the procedure that's showing up right now? So that undifferentiated shock is sort of what was at the top of the differential at this point. So obviously this patient was initially started on fluid resuscitation because he was very hypotensive. However, the blood pressure did really very minimally improve following the fluids. And then vasopressors started right away. However, I think I have yeah. However, as we were thinking about what to do next, obviously this is someone that is very unstable to go to a CT scanner. You can't really take him to the scanner. Once you go through your ABCs, check his airway, make sure it's okay, listen to his lungs. Obviously you have your blood pressures for the circulation and everything. The next step was to bring the ultrasound machine. And the first thing that we actually looked at was the abdominal aorta, and it was okay. There was no dilatation of the aorta. And the next thing was a cardiac focus. And this was an actual image of from the patient. So as you can see here, anybody want to chip in and jump in with what they see going on in this image? You can type it.
Bernard says, wow, tamponade.
Okay. Yeah, this was very, very, very obvious. You could clearly see this anechoic sprite here showing the pericardial effusion, and this ventricle is really, really, really collapsed. It's not able to do anything. And in this image too, you can see it better. So obviously at this point, the main focus was to try to get this fluid out of this patient pericardium. And he was not stable enough to go to any cath lab or call any cardiologist. So it was just us, the emergency physician, to try to fix this. And this is an actual image of the pericardial synthesis. And you can see here this needle going in. And yeah, this is a linear view of what happened. And then this is afterwards. This is what happened after the fluid was drained. As you can see, the right ventricle is very happy now. It's opening up, and the fluid is not that much anymore. So all you needed in this case essentially was a POCUS and a needle to fix the patient, for the most part. So POCUS saves the day, and this case sort of highlights the importance of cardiac ultrasound, especially in a critically ill patient. So that being said, we'll go ahead and the resolution of the case. Patient ended up going to the CT scanner after the pericardiocentesis procedure. He ended up getting another revision of his pacemaker, and the CT did show that he had a perforation of the right ventricle from one of the lead pacemakers. So that's what caused the tamponade. And then eventually he was in the ICU. Ultimately, he was discharged home with a new pacemaker. So basic cardiac
Abdoulie,
focus.
we have a couple questions before you move on. Ruth wants to know what was drained. So did you end up doing it in the emergency department? And then did they do a window upstairs? Yeah, okay.
Yeah, so we did a, sorry, I didn't get to the details of all of that. But yeah, we did drain, and it was a very interesting procedure because I don't know if you've done it with this kit, but we essentially used the micropuncture kit instead of the actual pericardiocentesis kit. And that was the first time I ever used a micropuncture kit to do this procedure, and I think everybody should use the micropuncture kit right now. It went really smoothly and really smooth, and we got 30 cc's out initially, and the blood pressure just normalized from that, and then he was off of the levopressor. And he obviously ended up putting the catheter in and leave the catheter in there and drained it down. So they ended up going to the cath lab, the cardiac thoracic surgeon. But yeah, they did put a window. They left it in I think they left it in for almost 3 days before they even do a window on him because it was just working just fine.
Wow.
They ended up doing a window and the pacemaker replacement, the vision.
I assume it was blood that came out.
It was all blood. Yeah, it was all blood.
Wow.
Yeah, it was all blood. And that brings another point to I know, now POCUS is very common, but back in the day they used to do these procedures blind. And I don't think I can do that because when you pull blood out, the question is, where is that blood coming? Is it from the ventricle or is it from the cardiac space? So POCUS can help you avoid that, get into the ventricle. So yes, it was all blood, and he ended up going to get a pericardial. So basic cardiac ultrasound. This is a very important skill to have, especially with critically ill patients. I sort of train my brain to whenever I see a sick patient, the next thing, I know this is not the traditional way of teaching or even approaching patients, but my brain sort of like automatically thinks of POCUS whenever I have a sick patient, especially when I have a hypotensive patient. I always grab it with me if I have it into the room. And it allows for very rapid evaluation of hemodynamic changes in cardiac etiologists. And if you have any patients who is hypotensive, patients that are shoulder breath, patients that are, chest pain that's pretty much undifferentiated, and you don't really know what's going on, but they still having persistent chest pain, everything else is coming back normal or unremarkable, you can grab the ultrasound, and it can help identify, wall motion abnormalities and things like that. Dizziness, shortness of breath, dizziness, and syncope. And if you have significant EKG changes and you don't really know where it's coming from, to grab the POCUS. And we'll talk about what to look for in all these exams. And cardiac arrest too. I've had a few codes, cardiac arrest cases where no one can really feel a pulse, right? And as we know, the data is actually very clear on that. We are not very good at feeling pulses, especially when it comes to cardiac arrest manually. So I've had cases where no one can really feel a pulse, and then you take the cardiac probe, put it on the patient's chest, and the next thing you know, you have some cardiac activity, and that can help you direct your resuscitation as well. So the approach to the exam, you don't need much. The patient has to be laying down flat, pretty much on their back. And you do need this probe called the phase array probe. This is a small probe, and some people call it the cardiac probe. And depending on, you always need the cardiac preset on your machine. Different machines have different ways of how to access the cardiac preset, but it's pretty much, a lot of these machines would have a picture of the probe and that you can just click, and there's somewhere on the screen you would see cardiac
Is the
exam.
temperature which you are is 20?
Cardiac exam, and you can click that. And obviously you need a lot of gel. I always warn my patients that there's going to be a cold gel on their chest, because most of the time they don't expect it. And it's good to give them that warning as well. Just some basic anatomy. This is something that we are familiar with. One thing to keep in mind is the IVC. We always have to look at that as well, based on doing the cardiac exam. And the other things that I always sometimes tend to forget, and this may be out of the scope of this lecture, but it's the valve, right? The cardiac valve. That's something that you can look at too while you're doing your exam. And sometimes you can see very obvious things in there, like vegetation that can give you an answer to the question that you're looking for. So we'll talk about the basic cardiac views. Essentially, these are just 5 basic cardiac views that you can do when you're doing your ultrasound, and they're all listed here. The most common one, the first one that I typically do is the peristernal long view. We'll look at that. We'll take a look at how to do that, or how to get that view. And there's also the peristernal short view. We'll also take a look at how to do that. And we also have the apical 4-chamber view. This is usually the most difficult one to get.
Okay.
And we also have the subxiphoid view. This is the view that most people are somewhat familiar with. This view. If you ever do a fast exam, this is normally what you get when you're doing a fast exam. And the last but not the least is the inferior vena cava, the IVC. And we'll talk about all of these views, but once you're able to get the subxiphoid view, it should be very easy from there to get the inferior vena cava view. So this is what the peristernal long view looks like. Is essentially, you have this picture here, and this is just a graphic representation of what it should look like on the ultrasound view. So the most important thing here is your probe marker. If you look at this image here, you'll see that the probe marker here is facing the patient's right shoulder. So a lot of times what I do is I just put the probe marker facing this way, and I scan my probe down towards the left shoulder. So as you can see here, the probe marker is facing the right shoulder, and you can move up and down like that, because sometimes people have different windows, especially when you have patients with COPDs and they have emphysema. Sometimes the window, the peristernal lung view window, would be all the way down. So if you're starting here and you don't see anything like this, you can just slide down until you see something like that, or you can slide up until you see something like that. But the most important thing is to make sure that the probe marker is facing the right shoulder of the patient. And as you can see here, you're able to see the left ventricle in this view. You're able to see it the left atrium. You also see the interventricular septum, and this is the RV. But essentially, really, it's the RV outflow tract, but it's part of the RV, the right ventricle. And obviously, you can see the aorta, or the base, the aortic root. This is showing you the aortic valve too as well. And we'll talk about this later on as well. It's a very important structure. So this is pretty much all you need for the peristernal lung view. Put your probe on the patient's chest, typically on the left side, to make sure that the probe marker is facing the right shoulder, and then you can slide up and down to get this view. And once you get the peristernal lung, you can move on to the personal short view. So typically, you don't even have to move your probe that much after you get the long to get the short. So what you do is when you get the long view, all you do is you rotate your probe marker. Just rotate it so that the probe marker now is facing the left shoulder. And if you don't get this view, what you can do is you can slide up or slide down. And what you want to see is something like that. And you want to see this papillary muscle. That's the level that you want. Sometimes you'll see what we call the fish mouth. That's essentially the mitral valve opening and closing. And you can see that as you move up towards the right shoulder. So essentially, you get the personal long view. After you get that, just rotate your probe. Make sure that the cardiac probe marker is facing the left shoulder, and you should be able to see that. Moving on to the apical four-chamber view. This is, like I said, sometimes the most difficult one to get. But one thing that helps a lot is whenever you have your personal short view, what you can do is slide all the way down. Let's say you're here, and then your probe marker is facing that way. You leave it there. But what you can do is you slide the probe marker down all the way beneath the nipple line. And then once you get to that level, you can lower the probe angle. Once you lower it, you should be able to see something like this. Now, sometimes it's very difficult to get all of this. What you can do is you can have your patient lay on their left side, like in the lateral recumbent side. That can help bring their heart into view sometimes. Or you can also move a little bit more lateral if you're not able to see something like that. So what you want to see is the mitral valve, tricuspid valve, and then the septum. Obviously, this is the RV wall, and this is the right ventricle and left ventricle as well. Again, just once you get your personal short view, slide down, lower the probe, and you should be able to see something like that. And the other view that most people are familiar with is the subxiphoid view. And this one, essentially, you put your probe underneath the subxiphoid, underneath the xiphoid part. Yes. And sometimes it can help when patients take a deep breath. When they take a deep breath, and again, I forgot to mention, on this one, the probe marker should be facing this way. And essentially, your probe should be facing, the entire probe sort of should be facing that left shoulder. So patients can take a deep breath. That can help bring that cardiac, that heart anteriorly, and you can see something like this. And again, on this view, this is the actual view that you saw on that patient that I shared earlier. And you should be able to see the septum, or the left ventricle, and then the atria as well. And this is just a graphic representation of it. And the last but not the least is the IVC. So once you're here, one thing you can do is just rotate your probe. You can leave it there and then rotate your probe so that the probe marker is facing the patient's neck like that. So if you look at here, all he did was right there. You can just rotate upward, and then you should see something like that. And one thing to keep in mind is when you're looking at the IVC is that sometimes you can have the aorta come into view when you're doing the IVC. And it's very important to differentiate this, because the aorta is always going to look like it's very dilated, right? And if you're mistaking the IVC for the aorta, you might think the IVC is very dilated, when in fact you're looking at the aorta. So it's very important to differentiate the two. And one way to do that is look at the pulsation of it. If you scan and you see something that looks like this, but it's pulsating, you pretty much know that this is not the IVC, but this is probably the aorta. And the other thing too, you'll see that the aorta has thick walls as well. But the pulsation is what typically helps me a lot. And one thing that you can do whenever you are here to differentiate the IVC from the aorta is you can tilt your probe to the right and tilt your probe to the left. If you do that, you should be able to see the aorta. And then if you tilt it the other way, you should be able to see the IVC side by side. That's how I usually try to differentiate the two. So just to summarize a little bit, these are the 5 basic views of the POCUS, cardiac focus. There are other advanced views, but pretty much this is what you need for the basic level. Any questions so far?
If you have any questions, feel free to chime in the chat. And I can feel free to answer those while we get the ball rolling with the rest of the slides. Thank you so much, Abdoulie. This is awesome. Great review for everyone. And for some people, it sounds like they don't have access to point of care ultrasound, but they're trying to learn. So this is all new information, which is really great.
Great. That's great. So yes, these are the 5 basic views for cardiac ultrasound. When you're doing a cardiac ultrasound, these are the views you want to. Now, I want to mention one thing is that whenever you grab the ultrasound probe to do a cardiac ultrasound or any ultrasound, you should always have a question in mind that you want to answer. Okay, I have a suspicion for pulmonary embolism. I want to know if this patient has evidence of pulmonary embolism, and try to answer that question. But these views give you a comprehensive overview to not miss anything. So, like I said, you should always have a question in mind, but what do you do with all these views, right? How do you interpret all of these? This is something that usually makes people uneasy. I've had people tell me, well, I can get all these views, but I don't really know what to do with it. I'm not comfortable interpreting. I'm not a cardiologist. You don't have to be a cardiologist in this scenario in the ED. There's a very well-written, comprehensive protocol that helps us answer this question, that helps us interpret these images. And this is a paper that was written about that protocol, and it's called the 5 E's. It's very easy to remember, honestly. Usually when I grab an ultrasound probe, I'm running through all these 5 E's in my head and trying to answer every single question that these 5 E's are asking. And the 5 E's are effusion, ejection, equality, exit, and entrance. And we'll talk about what each and every one of these means. And you'll see that it's really easy to remember all of them. And as you're answering these questions about the 5 E's, you're essentially interpreting your POCUS result. So the first E is effusion. So effusion here, we are talking about pericardial effusion. One thing to keep in mind, and for pericardial effusion, as you might have seen on that case that I shared, it's usually a black stripe that's surrounding the pericardium. I mean the heart, and we call it this anechoic texture. You can see here, all of this is fluid, and all of this is fluid as well, and it's all surrounding the heart. One thing to note is that always try to get multiple views when you see a pericardial effusion. And the reason why that's important is because sometimes you can have a focal effusion. You can have an effusion that's just here, right? And it's not necessarily there. And if you don't have this image, or let's say you got a person or short view, you may not see this fluid, or you may not even see how much fluid is in here. So it's always important to get all the 5 views whenever you're looking for a pericardial effusion. The one thing I wanted to mention too is that TB is the most common cause of pericardial effusion in developing world. So if you have a TB patient who is not doing well from or not responding to therapy the way you would expect, you can consider doing a cardiac ultrasound to see if they have a tamponade or if they have large pericardial effusion that may be contributing to their etiology. And it's also important to differentiate pericardial effusion from a pleural effusion. And these images don't really do justice on how to do that, but I'll try to explain. So one thing that I mentioned that we'll talk about later on was this picture here. This is the descending aorta. And as you can see, this fluid, it runs above, almost right next to or above that descending aorta, right there. That's the pericardial effusion. Now, sometimes you'll see a lot of fluid underneath there, right here, somewhere here. It's gonna look like it's next to the heart, but it's running below that descending aorta. That is not a pericardial effusion typically. If you see any fluid running below that, that's usually a pleural effusion. So always keep in mind, as you can see here, this is the descending aorta, and here the fluid is above that descending. So that's how you typically differentiate pericardial effusion from a pleural effusion. The other thing to keep in mind too is sometimes you can see a pericardial fat pack that may look like a fluid, but it's usually not. And one way to differentiate that is you'll see that the fat pack would move along with that LV wall or RV wall, and it's not going to be usually not as flat as this is. So those are the two main things to keep in mind while you're doing checking for pericardial effusion. The last but not the least, obviously the most important, is to evaluate for cardiac tamponade. And I just wanted to talk briefly about cardiac tamponade here because it's very important. Not all pericardial effusions lead to cardiac tamponade. Sometimes you can even have a large effusion but no tamponade. Sometimes you can have a smaller effusion that can lead to tamponade. One of the main things that's important with cardiac effusion, pericardial effusion, is the rate at which that effusion is accumulating. All right, you have someone who got shot in the chest, they're hemorrhaging out into the pericardium. That is more likely to cause an effusion than if you have someone who is, let's say, a cancer patient or a dialysis patient who is slowly accumulating fluid into their pericardium. So I just want to talk about the two main things that are very important on these on this slide. One of them is this right here. This is the RV diastolic plaque. What does that mean? So typically what happens is when you have a pericardial tamponade, it's the fluid outside is going to push on this right ventricular wall down. So it's going to collapse even when it's not supposed to collapse, right? It's going to collapse during diastole. So the way to do this, or the way to check for this, is you look at the mitral valve here. So let's say this is the parasternal long view, and you're looking at the mitral valve. Once the mitral valves are open, that's in diastole, you can stop the image, you can freeze it on your screen. And what you do in that sense is that when you freeze it, you look at the RV wall and see what's doing, what it's doing. Is the RV wall collapsed or is it not collapsed? So if it is collapsed during diastole, that is very, very, very sensitive for cardiac tamponade. It's actually one of the most sensitive signs of pericardial tamponade physiology. And the other thing to look for is what we call the protoric IVC. That's if you look at the other 5 views that we have, the IVC was one of those views. If you look at it and it's dilated, that can be a sign of pericardial tamponade as well. If you don't have a dilated IVC, you should really question whether you have a tamponade or not. So these two signs are very, very important to know. This one is a right atrial systolic collapse. It's usually a very specific sign. It's usually the first thing that you see. But if you don't see it, that doesn't really mean that you don't have a tamponade going on. But if you don't see these two, you probably don't have tamponade. You also have to look at the big picture, right? You have a patient that's coming in who is very tachycardic, hypotensive, and they have a large fluid around their heart. Probably that's what's causing their symptoms, right? You have a patient who's coming in and they have a little bit of chest pain. They're looking very well. The blood pressure is okay. You know, vital signs are okay. And you look at their heart and there's a pericardial effusion there. You really can't tell whether you can see these things. You know, if you put A and B together, it's probably not what's causing it. The fluid is probably not what's causing it. Okay? So I would recommend just focus on these two. And this is just a graphic representation of this. So essentially what you can do is you can put what we call an M mode. If you've ever seen one, you can just hit it and it'll bring a line. Make sure that line runs through that mitral valve and you would have an image like this. Once you click it, you have to click it twice. You click it once, you see this line, you click it again, and it gives you this image. And then once you see this image, this line here that you're seeing represents the mitral valve, and this line here represents the interventional septum, and this line here represents the RV wall. So as you can see, this is diastole, systole, diastole, systole, diastole, systole. So during diastole, the RV wall is collapsed. So that's what RV diastole is. And it's a very sensitive sign for cardiac. Any questions about that? I know it's kind of a lot for this basic lecture. All right, so we'll talk about the next E. If you remember the 5 E's, it was effusion, and the next one is ejection. So ejection is referring to the LV ejection fraction. Right? This is essentially the LVEF of how well is your heart contracting, right? And you can assess for systolic heart failure. One thing that I use this very often because, you know, a lot of times you have a patient who comes in and they're hypotensive, right? And the first instinct is to give them fluid, right? Just run the saline in, right? But you want to make sure that they're not in acute heart failure too before you start fluids. So a lot of times I would get the fluids going, I would start fluids, but at the same time, I would have the ultrasound in there, looking at their heart and making sure that they don't have a very depressed or a very severe depressed LVEF. And you can either do this qualitatively or you can do it quantitatively. And honestly, there's been some really good data showing that ER physicians are really good at estimating qualitatively what the LVEF is. You can also do it quantitatively, which is looking at, one way to do that is looking at what we call the endpoint or E-point septal separation, which is just a surrogate for the LVEF. And we'll talk about that briefly as well. So for qualitative assessment, you can look at how well is the LV wall moving, right? Typically, the recommendation is you should look at the LV chamber, the left ventricular chamber, and see what the diameter, how much is that diameter of the chamber reducing, right? You have a chamber like this, and when the heart beats, it goes like that, right? And you have a chamber like this, and when the heart contracts, it goes like that. It doesn't really reduce, right? So how well is that LV wall moving? Or the other thing that you can look at is how well is the mitral valve leaflet. Matter of fact, that's kind of what you use to determine your EPSS. And for the EPSS, we'll discuss it in a minute. But if you measure what we call the EPSS, and it's less than 7, that's usually sorry, this is a typo. Okay, I'm gonna rectify here. Less than 7 is normal. Less than 7 is normal. This is my mistake. Less than 7 is normal, and if it's greater than 10, it's very wide. That is not normal. Okay, and I'll discuss that in a minute. So this gives you a look at what normal looks like. So if you look at these 2 slides, this is a hyperdynamic, meaning it's just squeezing. It's the LVEF is probably greater than 70% here. And if you look at here, look at the chamber. The chamber is getting a little bit smaller as this chamber contracts. And you compare that to this. If you look at this chamber, the walls are moving, but the chamber diameter almost the same. So that's about 30 to 44%. And here, if you look at this one, the chamber is essentially the same size as these walls are contracted. Let's do it again. All right. And the other thing to look at is, if you look at here, this mitral valve here is almost touching this wall right there. You can see that it's almost touching it, right? And then if you look here, this mitral valve is very far from that wall, right? So if you recognize the extremes of this, you'll be very good at recognizing LVEF that's normal or not. So this is the qualitative way of assessing this. And a lot of times you don't even need a quantitative assessment. All you need is just looking at the image and looking at the mitral valve and looking at the walls and see how well are these walls contracted. All right, this is the EPSS. So, like I said, this is a little bit outside of the scope of this discussion, but the way to do this is you get your parasternal lung view. If you remember, you put the probe on the chest. Your probe marker should be facing the right shoulder, and you should get a view like that, right? And then after that, just if you have an M mode on your machine, you can hit an M mode, and once you hit an M mode, you should see this line come into view. And make sure that this line is running across the mitral valve and the wall here. And once you have that, you should click the M mode again. And when you click it twice, you get something like that. And again, this line here represents the mitral valve leaflet, right? And this is diastole, systole, diastole, systole. And what you're trying to measure is this line here is the septum. And what you're trying to measure is the distance between here and here. This is the distance that you are interested in. And that's what the EPSS is. And like I said, that other slide that I made, there's a mistake there. Because what you need to see is that in a normal patient, this point should be very close to this line. And if it's less than 7 millimeters, that means it's very close, and that's pretty much normal. But if it's more than 10, there's always this question about, well, what about between 7 and 10? That's essentially asking the question of what is, what about the LVEF of, 45 to 50 or 50 to 55? That's usually a borderline. Okay. What we're interested in the emergency department is usually the extremes. If you have someone who comes in and you measure the EPSS and it's from here to here is more than 10, that's usually very abnormal. So that was the ejection. The next one is equality. Equality here is talking about equality between the left ventricle and the right ventricle. So normally the right ventricle should be about 0.5, half of the size of the left ventricle. If you do a POCUS and you get your 4-chamber view, this is your apical 4-chamber, and these two, this is the right ventricle, it's left ventricle, and these two are equal in size, that's not normal. Now, if this one here is more than, it's greater, the size, the diameter of this is greater than the LV, that's even way more abnormal. And why is that important? It's important because RV strain, right ventricle strain can cause that. Essentially, if you have a lot of pressure in the right ventricle, that can cause an increased size in the right ventricle. And that pressure can come from, the most commonly what we deal with is pulmonary embolism, right? If you have a shadow pulmonary embolism or a big pulmonary embolism that's causing pressure to back into the RV, to backflow into the right ventricle, that can increase the size of the right ventricle. The other thing that you can see when you are assessing for RV strain or possible pulmonary embolism is something called the D sign. So normally speaking, if you look back in a slide that we had for the parasternal short view, what you would see is you'll see a round left ventricle, around like that. And you'll see another round but smaller right ventricle. Now in RV strain, what you would see is that the septum, instead of being a round structure, is going to be a straight line, right? And why is that? The reason why that is because there's so much pressure in the right ventricle that is pushing into that septum, to making it a straight line. And as you can see here, this looks like a D. So, and that's where the term D sign comes So if you see something like this, you should be very suspicious of pulmonary embolism. Now, to put a caveat to that is that sometimes when you have a chronic pulmonary hypertensive patient, they can have a very enlarged right ventricle. One way to differentiate the two is you can measure the wall of the right ventricle. That's a little bit outside of the scope of this discussion. You can measure the wall of the right ventricle. If it's less than 5 millimeters, usually that means that it's very acute, likely pulmonary embolism. If it's more than 5 millimeters, it usually means that it's something chronic and could be from a pulmonary hypertension. But when you're doing the POCUS, you have a question in mind. You already have a suspicion, right? Someone comes in, they're a cancer patient, they're short of breath, they're having chest pain. It might be a PE, but they're not stable enough for you to take them to the CT scan, or you don't even have a CT scan. You already have a suspicion for that, and then you do a personal short view, and you see something like this. You should be very, very, very suspicious for pulmonary embolism. So the next one is the exit. The exit is talking about the aorta, as that's how the blood exits the heart. So it's the exit from the heart. And the two main things that you're looking at in this view, in this windows, are the thoracic aortic aneurysm and dissection. Most commonly dissection. Now, dissection, the gold standard is to get a CT scan if you have it, but if you don't, POCUS can help with that. And the first thing that you look at is the size of the aorta, right? As you can see here, and this is not a very clear picture, but if you see here, this is the aortic root right there, right? And the measurement should be less than 4, typically. More than 4.5 centimeters is usually aneurysm. It's usually abnormal. Now, you can measure it, but one way that you can qualitatively look at this is you can look at the root, and you can look at this here, this structure here. That's the left atrium. Typically, the left atrium should be bigger than that, right? Now, if you're looking at this image and you're seeing that the left atrium is less than that aortic root, that's probably an abnormal aortic root. Probably very not normal. So you don't even have to measure it. If you look at this very image, you can see that this root is all the way from here, and it's definitely greater than the left atrium. And the another thing that you can see is you can actually see what looks like a flap. What looks like a flap, and a flap essentially is a hyperechoic, meaning a very white straight line that you can see. And if you look here, this is not very obvious here, but you can see that line there. And that is a flap. And to make it very clear here, as I mentioned earlier, this structure is very important. It is the descending aorta. And if you look at this image, you can clearly see that something's here, something inside there. That line, that is definitely not normal, right? And that is an intimal flap. That is obviously a aortic dissection. And let's say this patient is not stable for scan, or you don't have access to it. This image should be sufficient to diagnose aortic dissection. And the last one here is the IVC. Again, to get the IVC, you get the subxiphoid view right here. And once you get that, you twist your probe towards the neck, and you should see something like that. Again, the IVC is very important for two main reasons. There has been some controversy about how well does the IVC really assess for fluid status, but it's really a good measurement or tool or surrogate for fluid status to use. Typically, like I said, in the ED or in the emergency department or in the critical care setting, we care about the extreme, right? So if you have a patient who is septic and you're worried about a fluid overload, you're worried about whether this patient can have more fluid or not, you can check their IVC. And if you look at this image here, right here is the IVC. And one way to know for sure if this is the IVC or not is to see where is this structure leading into, right? This right here, this is a still image, but if you look at this, it's leading into the right atrium right here. So always look at where that structure is leading into. to help you determine if that is the IVC or not. And if you look at this IVC, it's very, very collapsed. You don't even have to measure this. It's definitely less than 2 centimeters. If you look at this one here, it's very dilated. And one thing to always look at is what is the change of the collapsibility, right? Is it more than 50%? Is it 100%? Is it not? Is it completely collapsing like this? I put this image here just to show the difference. If you look at this image, this is actually the aorta. This is not the IVC. And one way to know for sure is that this is not leading into it's not leading into the right atrium. And the other thing to look at when you're looking at the aorta is to see if it's pulsating or not. If it's pulsating, it's more than likely aorta and not. So those are the 5 E's: effusion, ejection, quality, exit, and entrance. If you answer all these questions while you're doing your POCUS, you essentially just interpreted your POCUS. For the effusion, you're looking at pericardial effusion. For the ejection, you're looking for evidence of heart failure. What is the LVEF? For the entrance or the exit or the quality, you're looking for evidence of pulmonary embolism or RV strain. And the exit, you're looking for aortic aneurysm or dissection. For the entrance, you're looking at the IVC and assessing for fluid status and response. So that was pretty much much of what we have for basic cardiac ultrasound. If you have any questions about it, you can feel free to write it down in the chat, and we'll answer as we go. The next case that I have is essentially for a abdominal ultrasound. And abdominal ultrasound it has a wide variety of things to discuss. So I think we could pretty much just focus on the abdominal aortic aneurysm at this point. And the case I have here was a 71-year-old female who presents to the ED following a ground level fall. Fall was unwitnessed. You know, this is just the classic ER patient. It comes in and they're very confused, and sometimes you don't even know what the name is, and they can't tell you anything else. And you know, you can't get anything else, right? There's no family. Maybe the ambulance folks can't really get anything else from him or her as well. And again, you look at this patient, they're very sick, hypotensive, tachycardic, respiratory rate of 19, O2 sat is 97, the temperature is fine, they're confused again, they're not really able to tell you anything. They're ill appearing, pale, diaphoretic, and the rest of the exam looks okay. So this is the type of patient that is, you know, anything is on the table, right? These vitals or this presentation could be anything, right? Could be essentially undifferentiated shock. But again, always remember abdominal aortic aneurysm, especially rupture, when you see someone like this as well. Especially if everything else is coming up normal, or you're not really able to figure out exactly where or why they're hypotensive. And again, this patient is not stable for CT scan, and you don't even have a CT scan. The next step, obviously, make sure you do your ABCs, check the airway, breathing, circulation. And after that, grab your ultrasound and start scanning. And this patient, you know, you scan this patient abdomen, and this is what you see, right? Anyone want to define what they see? Obviously, here, if you look at it, this is pulsating, and this is clearly a abdominal aortic aneurysm, which is very big. And we'll talk about this in a minute, but if you see an aneurysm of this size, a lot of times you're not able to see. I think I've only seen one obvious extravasation, one obvious rupture where you can actually see the rupture or the site that's ruptured. So it's very difficult to see that rupture itself. But what you're concerned about, or what you should be focusing on, is the size, right? If you have a size, talk about it here. If you have a size that's more than 5 centimeters, like this here, that should raise concern for a rupture, even if you don't see that rupture itself. Again, aortic aneurysm can be diagnosed with abdominal aneurysm can be diagnosed with bedside ultrasound. There's been a good literature showing that we are actually very good at evaluating for this. Sensitivity almost close to 100%. And to do this, you're going to need the curvilinear probe. This is the probe that has, this is the biggest probe. So just usually you have the phase array probe, which is the cardiac probe, and that's the smaller probe, and there's a linear probe. And the biggest probe is usually the curvilinear probe. This is, some people call it the abdominal probe. Little bit of anatomy here. Typically, sometimes you're able to see all these branches, the celiac trunk, the SMA and the renal arteries. But what you're interested in is the abdominal area itself. So even if you're not able to see these, that's okay. Yeah, I'm just focused on the abdominal aorta. So how do we do that? You use your the curvilinear probe, and make sure you always start right there underneath that subxiphoid process. And you should, a lot of times when you press it there, should be able to see something like that. Now, sometimes you don't automatically see that. Sometimes what you see is a lot of bowel gas underneath it. And what you do in that situation is just try to keep a very steady pressure down, not too hard. And sometimes the patient can take a deep breath while you're doing that to get that gas out of the way, to get that bowel out of the way. And when I do this, I don't even look for the aorta in the beginning. When I do it, the one thing that I look for the most initially is that. This is the vertebral body. This is at the back of the patient, right? So this is sometimes called a spine sign. There are, I think, 2 other spine signs, but this is one of them. So what you do is you see something like this that's round and has this shadow all the way down. And right on top of that, you should see this image here. So sometimes you just look for this vertebral body and look what is on top of it, right? And I forgot to mention that your probe marker should be facing right. This is the indicator right there. And then once you see that, look to your left, you should be able to see the IVC as well. And again, sometimes the IVC may look like the aorta, but you can just assess to see if it's pulsating or not. Sometimes you can also assess to see the wall of the aorta, how thick is it. And usually it's on your right side. And once you get this image, this is the short axis view. And you can also look for the long axis. And to do that, you can just see how this person here in this image is doing that. So once you get the short axis, all you do is you rotate your probe to make sure that its probe marker is facing the patient's head. And once you do that, you'll see this image turn into this image. And the reason why this is important to do is sometimes you can have an intimal flap from a dissection that's not showing up on the short axis. And when you do a long axis, you'll see this white line running inside of it. And that can be that from a dissection. All right, so how do we interpret this? This one is a lot easier than the cardiac ultrasound. You don't really need a lot of views. Pretty much I mentioned here, when you do this, you start from the subxiphoid and always make sure that you're scanning all the way down to the bifurcation of the aorta. And that usually corresponds to the umbilicus right here. So scan all the way down. The reason why that's important is because sometimes the abdominal aortic aneurysm can be focal. It may not be up here. It may just be like that. And actually, a lot of the AAAs are intrarenal, meaning that they're below the renal vein. So if you don't scan all the way down, you might miss a AAA that's down below the renal vein. And typically you see something like this. One of the most important things to do when you are doing an abdominal aortic scan is the measurement, okay? So as you're looking at here, you see what looks like a wall here, and there's another wall here, right? So always measure outer wall to outer wall, right? Because if you measure inner wall to inner wall, you're gonna miss the actual size of the aorta. And because a lot of times what happens is you have a AAA and you're gonna have this hypoechoic structure here, and this is a clot. This is an intraluminal thrombus, and this is still inside the aorta, but it's making it look like the size is just that, when in fact the size is from here to here. And again, this is the vertebral body. This is the thing that I look for in the first place. Once I see it, I'll move up and look at that. And this is definitely more than 5 centimeters. It's right here, 7.4 centimeters, 4.6 centimeters. And even though you're not able to see any evidence of rupture here, this is this size is ruptured until proven otherwise. This patient should be resuscitated very rapidly. If you have access to a vascular surgeon or thoracic surgeon, they should be called to repair these. And again, aortic diameter greater than 5 centimeters is indicative of rupture until proven otherwise. And make sure when you're scanning, you scan all the way down to the umbilicus. So just to wrap it up here, you know, remember to utilize POCUS, especially when you have a critical ill patient. If you have a patient that's sick, you can, once you do your ABCs, the next thing, you can grab your ultrasound machine, look at your cardiac views, and again, go through your cardiac views, go through all the 5 E's as well, especially in a hypotensive patient. And remember the cardiac views. Remember to position your cardiac probe marker in the right spot to get the right view. And then remember the 5 E's, right? When you're doing your cardiac view, go through your 5 E's: effusion, equality, ejection, exit, and entrance, and interpret all of those as you're going through. And then make sure when you're measuring the abdominal aorta, make sure you measure from outer wall to outer wall. That gives you the exact measurement. And when you're doing the abdominal aortic measurement, make sure that you're measuring from the subxiphoid area all the way to the umbilicus as well. And sometimes you can actually see the bifurcation of the aorta into the common iliac arteries as well. And sometimes you can have aortic aneurysm on those bifurcations here as well. So that brings us to the end of our discussion. And here are some of the questions that I had. And I'll just thank everybody for coming. And if you guys have any questions, I would be more than happy to help.
Abdoulie, this was absolutely fabulous, so thorough, and you covered like so much information that it takes months sometimes to learn in residency or other forms of training in an hour and 15 minutes, about an hour actually, because we started late. So thank you. I know. It's awesome.
Thank you.
And the feedback so far has been really positive. I would love to hear from you guys. It sounds like people really enjoyed this. So please do submit feedback in the Google Doc that I just posted. And we would love to have Dr. Gaye come back at some point in the future if he's willing to join us again to teach us more things about ultrasound. I'll give about 2 to 3 minutes for everyone to answer the post-participation questions, and then we'll quickly go through the answers and wrap up for the day. I know we're running overtime, so thank you guys for your patience and for being so engaged and asking questions and participating in the chat throughout. So I'll let you answer these questions. All right, folks, I'm going to end the poll and share the results so you can see them. Can everyone see the results? Yeah. All right. So the first question was, which of the following findings on cardiac POCUS most strongly suggests cardiac tamponade? And the correct answer is right ventricular diastolic collapse, or D. And these will all be released in the post-session summary too, if you want to review them later. Some people answered thickened pericardium, which we would see in pericarditis, like things like tuberculosis involving the pericardium can cause a thickened pericardium. But right ventricular diastolic collapse is the right answer here. Number 2, the EPSS or endpoint septal separation less than 7 is actually normal ejection fraction. And we did have it as a typo in the slides. I have fixed that in the version that we're sharing with you. So I'm sorry for any confusion we caused. But greater than 10 millimeters correlates with severely depressed ejection fraction. Aortic root dilation, we wouldn't be looking at with the EPSS. You obtain an EPSS in the parasternal long axis view, and we wouldn't really see the aortic root well in that view. Sometimes you can, like at the bottom of your screen or posterior to the heart, but it's easier to see it actually looking in the suprasternal notch, which we didn't cover today. Number 3, when assessing the abdominal aorta for aneurysm, which measurement rule is correct? And the answer is outer wall to outer wall. You guys all got that right. This is one of the few things that we measure outer to outer. Most other things like gallbladders, other stuff is all inner to inner, and we'll talk about that in future sessions. Number 4, which aortic diameter should raise concern for possible rupture of abdominal aortic aneurysm? And the answer is 5 centimeters. You all got that correct. I think most of us have to memorize that at some point in medical school or nursing school, even if we don't know how to do point of care ultrasound ourselves. But that, I think, is a key point when you're doing it yourself, to be very nervous if it's 5 centimeters or more. And finally, a patient with hypotension and suspected volume depletion is most likely to have what IVC finding on POCUS? And the IVC is the inferior vena cava. So if they are hypotensive and they have volume depletion, we would expect the IVC diameter to be less than 1 centimeter with complete collapsibility. So remember, the IVC has respiratory variation. It's a low pressure system. So when we breathe, it changes in size. And if we're volume depleted, it can be completely collapsible. A dilated IVC with greater than 50% collapsibility would suggest that the person does have some volume in the system. You can think of the IVC as representative of the pipes in the body. If it has greater than 50% collapsibility, that means that yes, there's solid respiratory variation. So maybe, they could take a little bit of fluid, but anytime someone has a dilated IVC, I'd be cautious to give them more fluid. So a patient with hypovolemia or volume depletion should have a completely collapsible IVC. Abdoulie, anything to add to those?
Yeah, I think you summarized everything pretty much. Again, that was my typo on that. Greater than 10 is severely depressed. Typically, is greater than 10 is abnormal for the EPSS. And again, outer wall to outer wall, or and if it's more than 5 centimeters, be concerned about a rupture as well.
Awesome. Thank you, Abdoulie. And Bernard just asked, are these rules applicable in children? And yes, it's all the same in a kid as it is in adults in terms of IVC, in terms of looking at right ventricular diastolic collapse and tamponade, the way we look at ejection fraction, everything's the same. So it's one of the few situations where kids are little adults and not just, separate beings. Well, folks, thank you so much for your participation. A big hand to Dr. Gaye, who invested a lot of time into making this lecture wonderful for all of us. We will send out the summary document and the link to the YouTube video, as well as the answers to these questions within the next few days. And thanks again, everyone. Great to see you, and we'll see you again next month. Thanks, Abdoulie.
Thank you, everybody. Thank you so much.
Well done, Abdoulie. Well
Thank you
done,
so much.
Jess.
Thank you.
Thank you, Emmanuel. Appreciate you. And Abdoulie Touré, I just saw your message. Presentation regarding ophthalmology. Yes, we would love that. Please message me on WhatsApp. We'd like to get you on the schedule if you're interested in helping out, or if you have a specialist in ophthalmology who'd like to come and talk. Thanks for the suggestion. Take care, everyone.
All right. Thank you.
Thank you.
Thank you so much, guys. Thanks for all the participation.